Thank you for your kind introduction, and thank you again, the organizers of RheumaCon, to give me an opportunity to speak on this occasion. So as far as the conflict of interest are concerned, they are none relevant to this presentation. So this is just an outline of my talk. I would be starting with a case scenario. And this is a 30-year young male who had been having chronic back pain for almost intermittently for 7 to 8 years, which he actually went unnoticed. So it was just a mild pain stiffness, which used to be worse in the morning, and he used to be up and about. And it was just 3 weeks story, which was having a pain in the right buttock and radiation up to the upper thigh. He's a gym enthusiast, referred to me by a colleague, an extended family to him, and seen in a clinic, and with the notion that I have sciatica, because this is what he has been told by his local practitioner, and his pain was worse when he was sitting for long periods of time, because he does an IT job remotely. His review of system for spondyloarthritis was totally negative, except a family history of a maternal uncle who has back pain but has never been evaluated for that. And his pain actually gets better with pregabalin. So what are your thoughts at this stage? Any thoughts? Any fellows in training? So any our colleagues sitting here? So it's like a variable character kind of a situation in which he can go both ways. His Schobers comes out to be 4 centimeter, which was equivocal. His Faber on left side was positive with tenderness in the piriformis area. So I am in the clinic, I generally, once I have CRP, only then we can calculate STAS. But his first visit BASTI was just 1.7, which is like a very mild or inactive disease at this stage, if it is SPA, axial SPA. Rest of the musculoskeletal examination was totally unremarkable. The joints, anthesis, the skin, there was no SPA feature at all. And his neurological exam was also normal, meaning by he had a negative straight leg raise, and he had normal power, no issues with the sensation in the lower extremity. This was his X-ray like. So X-ray has changes of grade 2 bilaterally, symmetrical, but they are more in the upper 1/3 or half rather than the lower. So it would be by modified New York criteria. So if observer, there would be a lot of inter-observer variability when you report such X-rays. You can easily say that there are equivocal changes, and someone may say that it's like a grade 2. So at this stage, so the first, obviously, differential was axial spondyloarthritis. The second was the mechanical character of the back pain, considering that he has the tenderness in the piriformis area. So this might be a myofascial pain syndrome, a piriformis, prolonged job, IT. So sitting for many, many hours in a whole day. And then relevant investigations, they were ordered. He had MRI sacroiliac joints. So whenever you order an MRI, this is so very important that you do not write MRI pelvis. It has to be MRI sacroiliac joints, and it has to be done with semi-coronal sections. And the right technique, the sequences which you would like to see order would be the stir or short or inversion recovery sequences. His HLA-B27 was also sent at that stage, and his CRP and ESR as inflammatory markers. So this was the mind map going on. So if it's like a non-radiographic axial SPA versus radiographic, so would start him on NSAIDs, would refer to exercise, physical therapy, and if he's not responding, only then we would consider biologic. But what if it is just a mechanical problem going on in this young man, and you just wrongly label? At times you try to over-diagnose and overkill as well in the practice. So what if it's like just a mechanical strain? He just needs physical therapy, reassurance, postural correction, and then short-term use of NSAIDs and muscle relaxants and nothing else. So this was his MRI like. So MRI, when done properly, so can actually shows areas of osteitis and bone marrow edema. So this is periarticular subchondral bone in one quadrant, and then you can see that in some other quadrants there is also some hyperintense lesions, osteitis, and there is some early erosion over here as well, so, and over here. So there is an osteitis. And some streak of fluid can also be seen in the, so over here, so you can see a streak of fluid in the joint as well, which is also significant. And ASAS actually doesn't keep these capsulitis, synovitis, or enthesitis as a definition and the criteria, but it is basically the ASAS recommends having osteitis. Even in 2009, it used to be quantitative, at least have to be present in more than two consecutive sections or in more than two quadrants. But they have now revised their definitions for active sacroiliitis. Structural changes are still not part of it. So this is what exactly happened in these patients over a course of disease. A patient from here, which is a non-radiographic axial SPA, can evolve into radiographic, can develop syndesmophytes, and this can happen in every 1 out of 4 patients over a period of next 2 to 5 years. So which is actually a huge number, especially when patients are HLA-B27 positive and when they have a high CRP, because these are the predictors of radiographic damage. So considering the EULAR ASAS recommendations, you would start them on non-steroidal anti-inflammatory for at least 2 to 4 weeks before you escalate the treatment, and you would refer them to physical therapy. You would educate them about their disease, active lifestyle. This is not the kind of back pain in which you would really tell them not to do anything, not to bend forward. Rather, this patient has to be doing all kind of exercises, but obviously high intense exercises which can mechanical stress can also lead to inflammation. So he's a gym enthusiast. His gym training, the weight training needs to be modified as well. And then he has to have that measures of disease activity done periodically in the clinic, and then we decide whether to escalate the treatment or not. And the treatments which we can offer them are the TNF, IL-17, and even the JAK inhibitors. It seems that there is no one best fit for your patient. So you have to tailor treatment according to your patient. So this is the era where we are entering into precision medicine. And we know that there are pathogenesis, there are genes other than HLA-B27 as well, ERAP1, ERAP2, so there are IL-23 receptor genes, there are gut microbiome on which the studies have been done. And we need to really see which patients are the ones who actually require this kind of treatment, which we know that has its own implications, like giving TNF, like giving IL-17 inhibition, and even JAK inhibitors. So this is the era in which we are now entering. Maybe down few years, we would be having artificial intelligence taking over, and then that machine learning telling us which patient is the best patient. But I think that we are going to stay there, so human mind, so that is going to be the one, and we have to individualize treatments despite the fact that there are factors which are more objective, which can tell us about the disease progression. And if you look at the patient characteristics, someone, yes, a male gender, I would really worry. So they are the ones who are, it's considered to be male gender, a predictor of radiographic progression. Smoking. So by the way, this gentleman also smokes, accompanied by wife, and उसने कहा कि vape करता है. Vaping it still, I believe, is smoking, and this gentleman needs to stop smoking. Obesity, because of the mechanical stress, obesity itself has been considered to be one of the comorbidities which leads to difficult to manage disease. The biomarkers, the CRP and high ESR, even calprotectin, which can be done, but still not like validated to be used in clinical practice, and high disease activity scores, ASTAS and the BESTI, and the presence of baseline syndesmophytes. So all these patients in which you are actually doing a baseline visit, they should have lumbosacral spine x-rays, lateral view, and the cervical spine x-rays as well, in order to look for the presence of any syndesmophytes. And obviously, I have already talked about the MRI, and in a few seconds, I would be actually going over with these fatty changes as well. So this is just few insights from the ASAS, which I'm going to share with you. These are the representative images from the ASAS handbook, and this was 2019 when they updated. So if you have never ever seen before capsulitis, that the arrow over here is what exactly you would look for the capsulitis. This is bone marrow edema. Your patient has similar picture. This is more extensive. This is like more representative image. So you can see that there are images now which are other than that, which is a backfill edema happening in patients with where there is an erosion. So this is backfill edema. So this is hyperintense edema where the erosion is actually happening. And sclerosis. So these are the structural changes. Structural changes have not been made the part of active sacroiliitis criteria. But when you are looking at the MRI, remember, radiologists look from a different perspective. Most of the time they have no knowledge about the clinical symptoms. This is what exactly happens most of the time. So you have to read your MRIs yourself and have to develop that expertise. So looking at this is fat metaplasia in a patient which is like becoming now a chronic change. This is backfill happening that in an area which is a vertical erosion. And then this is a bone bud. So this is a bone bud which is ankylosis on the left side, and on the right you can see the bone bud. So these are the structural changes which you can appreciate on MRIs as well. But MRI, the best actually changes which you can see are either on the X-rays or on the CT. So you can see a erosion over here, the same patient, intense lesions seen which are more suggestive of sclerosis on MRI. So do not ignore these changes. And when you look at the latest modalities which are being used, there's a low-dose CT which is being employed for detecting syndesmophytes, and a type of scoring which we used to do on radiographs, which is an MSAS. This is a score which is done, CT syndesmophyte score using a low-dose CT. So this is a paper which was published in Research Musculoskeletal Diseases in 2024 January. And yes, deep learning is there now. These algorithms, they have been developed, they have been proposed, and they have been published this year in January. So there is a rapid, optimized. There are two algorithms which are being employed and are being considered as machine learning models for detecting MRI changes active of sacroiliitis in patients with suspected spondyloarthritis. And this is a paper by Nicholas J. So what is the evidence for treat to target? So treat to target, we know that patients who have a high STAS, they have a more disease progression in terms of radiographic damage. So this is what a cutoff which we generally aim at, which is considered a low disease activity at 2.1. So this is a composite of measures which are the patient-reported outcomes and obviously the CRP incorporated together, and you can compute it using just an app on your mobile and come up with a score. And I always tell my fellows that your understanding about the disease is really bleak if you cannot give a number to what is the disease activity at this point in time. For family physician practice people who are sitting here, ब्लड प्रेशर कितना है, 140/90 से नीचे लाना है, टारगेट क्या है, HbA1c का लेवल क्या है. तो the same actually has happened in the field of rheumatology. So we have come to now the targets that we have to suppress inflammation so that our patients can have better outcomes. This was the TICOSPA trial, which was published in 2021, which actually couldn't meet the primary endpoints. But when you looked at the secondary endpoints, ASAS 40 and the STAS LDA, so there was significant difference, there were more patients in the tight control group in which the disease in their treatment was being escalated using FCRP scores as compared to those who were having usual care. So what are the new additions in our therapeutic armamentarium? So this is what exactly we were having for many, many decades, just anti-TNF. So then we had IL-17 inhibition came in. Then we have JAK inhibitors. The first JAK inhibitor which was launched in Pakistan was tofacitinib. Opada was also approved for radiographic as well as for non-radiographic axial SPA. I think now in 24 we have bimekizumab, which is also now not available in Pakistan yet, but it is also approved, which is also IL-17 inhibitor, IL-17A and IL-17F inhibitor. So what are the factors which affect? So this is what I generally feel that these are the factors which we have to keep in mind as clinicians. The first is the disease activity, obviously, because we are treating to target. And then the comorbidities, a patient who is an elderly, patient who is young. So they are generally, expa patients are generally young. They tolerate these medications very well. So these drugs, when we have even concerns with cardiovascular safety, with infections, but these patients are the ones who have disease in their third and fourth decade, second decade of life. So they are the ones who are good candidates for these medications. If a patient has accompanying psoriasis, the guidelines say that moderate to severe psoriasis, your first choice would be secukinumab, which is IL-17 inhibitor, which is available in Pakistan. If you have a patient with recurrent uveitis, so then it would be a monoclonal antibody, adalimumab, infliximab, not Enbrel, not secukinumab. If you have IBD, so there is a caution, there is a warning with secukinumab using in patients because it can lead to worsening of inflammatory bowel disease. Then the choice would be monoclonal antibodies, anti-TNF as compared to other. And then the issues of access, what to do? You know what the medications are there, but people can't afford it. How are they going to afford? So the issues of access needs to be addressed. And this is one thing which we all have to really take care in our practices. This is the data which was the landmark trial which led to FDA approval by upadacitinib with ASAS-40 response rate of around 66%, low disease activity attained in 65, and ASAS inactive disease in 57. So this is very promising data. So I'm really intrigued the why upadacitinib has been performing well as compared to our other chicks on the block. So this is what exactly the data says, and you can see over here. So the upadacitinib is being represented in green, and this is the percentage of patients who have ASAS-40 response, and this is the STAS-LDA, and you can see over here. So this is up to like 67, 68%, up to 70% of the patients. They did so well that they were able to have their STAS less than or equal to 2.1. which is great happening in the field of expa in recent years. When you compare it with tofacitinib, so you can see tofacitinib hasn't performed that well in that regard because the ASAS-40 response rates are still hovering around, so this is 40%. 20% can happen even with an NSAID. So, and if now you compare them, so this is what exactly the comparison would look like when this comes to 40% improvement in the ASAS criteria. So upadacitinib is really performing well as compared to tofacitinib. This is the data, which is the bimekizumab, which is IL-17A and F inhibitor. So this is still not available, and you can see over here that the ASAS response rate in patients still is now in these patients after 52 weeks is around 40%. And this is the comparison between the three groups which we have now available in our armamentarium. So the JAK inhibitors, IL-17 and TNF in terms of ASAS-20 response, ASAS-40 and ASAS-60 response based on their landmark trials. And you can see over here the JAK are really performing well. Now coming to radiographic progression. So are we there now? So can we say that these medications, they can suppress inflammation and prevent radiographic progression as well? There had been some reports with anti-TNF. This is the images which are from a trial which was actually done by Alberta, the group prospective cohort on tumor necrosis factor inhibitors. They reduce spinal inflammation. Remember that 5% of the patients in XPA might not have inflammation in the SI joints. They might have only in the spine. And do not forget that these are also the posterior elements, the interior corners, which can show hyperintense signals if you do a whole MRI spine. This is still not advocated to be a routine practice because a lot of money then would start going into it. So, but the thing is, yes, if you suppress the inflammation earlier, there would be no fat metaplasia, there would be no bone formation. So that window of opportunity persists for AS patients as well. This is the Meyer 1 study, which was actually looking at secukinumab showing sustained efficacy and low structural progression in radiographic axial SPA over a period of 2 years as compared this was one comparison of secukinumab with adalimumab. It is a SURPASS trial. This is the cumulative probability plot of patients of having MSAS score at week 104. You can see that there is as such no difference. These are individual patients over here all over the period of time, and this is how we score actually on MSAS scoring: normal, erosion, squaring, early syndesmophytes, and then syndesmophytes giving a score of 3 on these sites which are in the lumbar spine and the cervical spine, the anterior corners. And this showed that spinal radiographic progression over 2 years was low with no significant difference between secukinumab and adalimumab. Now the regional data which we have been able to contribute and the local data. So our center and the center which Dr. Haroon works has been contributing to APLAR SPA registry. So the highest enrollment actually is from Pakistan. So I'm really proud of that around 20% of the data from all Asia Pacific is generated by Pakistan. So so far up to like 349 XPA patients they have been registered. This is the data as of this year, August. This was presented in APLAR. And if you look at the use of biological DMARDs and the TS DMARDs in this registry, this is around 67%, and this is what the pattern of these biologics is. Predominantly, it's anti-tumor necrosis factor, then is IL-17 inhibitors, and then would be the JAK inhibitors. And these are the outcomes. If you look at the outcome, I'm just restricting myself because this is for the psoriatic arthritis, and this is what STAS LDA. So patients are doing well when actually you are treating them to the target. This is a treat to target cohort. This is generating evidence in support of that. As of today, the ASAS and JULA do not recommend as such treat to target approach. They do recommend to measure disease activity score and to look for improvement of more than 1.1 in subsequent visits, but as such predefined, they say the predefined target, but the predefined target is now 2.1 or less. This is our cohort, which we have been able to establish with the support of Arthritis Care Foundation, looking at frequency of patients in whom this T2T, this treat to target approach has been employed, and the proportion of patients achieving the target of low disease activity at 6 months, 1 year, and 2 years using the ASTAS-TIA CRP cutoffs. So far, 309 patients have been enrolled. This is the data as of March 2024. The compliance to T2T was observed in 86.1% of the patients. These were the baseline characteristics. So still we have majority of our patients have radiographic XPA. Male gender is predominant. Diagnostic delay is around 6 years, mean. And this is the use of biologics, around 46.3% in our cohort. This is the pattern of the biologic being used. etanercept in 18.4, 33.8% IL-17 inhibition, secukinumab, and tofacitinib has really picked up. This data as is of 24 March, so upadacitinib has not been included in it. The outcome measures, if we look at the data, so it is really promising that STS-CRP cutoff was achievable in around 60% of the patients. Like 60% were doing great in our cohort on whether they were on biologics or not. When we looked at comparative efficacy of achievement of proportion of patients as CRP, it was highest with etanercept, and then it was comparable in secukinumab and tofacitinib. This is another study which we published in 2023 in Armed Forces Journal, which was secukinumab use, and again around 50% of the patients were achieving the target. And when we compared it with PSA we know that secukinumab IL-17 inhibition leads to more promising results with psoriatic arthritis and psoriasis, and it is up to like 57%. So this is the data which we presented last year in APLAR, which is about, again, comparison of tofacitinib versus secukinumab, and it is a retrospective study design, and we were able to come up that efficacy. If you look at the efficacy between tofacitinib and secukinumab, it was comparable. There was no statistically significant differences. This was an abstract which I presented at APLAR, or gender differences in disease parameters, adherence to treat to target, from the same data from the same cohort. HLA-B27 positivity is less as compared to men and females in our cohort, and the baseline was higher, which was statistically significant as compared to their counterpart men. The CRP was also high at the baseline as well as at the last follow-up visits throughout. So they have disease which is more active. When you looked at the disease parameters, so 25% of the females achieved the target, and it was 38.9 in men as compared to 25% in females. And the use of biologic DMARD was also higher in men as compared to women. So the burden of the disease in women is higher than in men in terms of BEST-I, but comparable as far as STS-CRP is concerned in our cohort. There is disparity in use in terms of biologics and TS-DMARDs. There is need to identify factors affecting biologic TS-DMARD use. The key message is treat to target strategy in cohorts is feasible strategy for generating local data. Despite the availability of newer biologics and TS-DMARDs, still 40 to 50% of the patients in clinical trials as well as in international and our national cohort, they will not be achieving the target. So we are still not there. And there is an unmet need for the nationwide registries and local guidelines considering patient preferences and cost issues. This is my mentor, Professor Nigar, Professor Sumaira, so at ACR, after presenting and this is my acknowledgements to institutions with whom I work. And thank you for your patience listening, and I hope to see all of you in PSR 2025 in Lahore in October as well. Thank you for your patience.